Thank you very much for the introduction. First of all, Manos, hello, I'm back here. Thank you for this. Manos and Manos, thank you very much for having me again in this beautiful city. I'm very happy to be here. It already, after being here for the third time now, and the waiter in the lobby, when I came and checked in the hotel, he already said, "Oh, you've been here before, right?" And I said, "Yes, that's right." So it feels a little bit like coming home. Thank you very much. So my task is to talk about chronic AC joint dislocations. And let me start with a case. If you look at this young guy, it's a 25-year-old sportsman. If you look at him, you will agree that this is a very unstable situation in the AC joint. On the left side, you can see the vertical instability. On the right side, you can see the testing for the horizontal instability. So I think we all agree this is a type 5 according to the Rockwood classification, as we heard. Who would treat this young guy conservatively? I can see 2 hands. Who would, 4? Who would treat it surgically? A little bit more, maybe double for surgery. And now I tell you the point correctly, Mr. Karahan. The point is, he has no complaints. He's coming 2 months after the injury, and he's only coming because of his friends, when he is climbing over body free, tell him, "You look weird. This looks not good. You should go and see a doctor." Okay? So I examined him. He has no problem. He has no complaints. He has no pain. He's doing all the sports he did before, and of course, he does not undergo any surgery. This is what we are talking about. Chronic AC joint instability, Rockwood type 5. And this is what we also have to talk about. If you look at the left side, this is also a typical case like we've seen right now. It's a chronic instability following a failed conservative treatment, which can be a problem. And on the right-hand side, this is a patient after having a hook plate that failed, and is also a chronic re-dislocation. So this is what we are dealing with when we are talking about chronic AC joint instabilities. So let me define the problem. This can lead to chronic impairment of shoulder function. And these are the people that need or want you to do something for them and that might need to undergo surgery. So the indication for the chronic ones is very easy, not like for the acute ones, which should we operate on. For the chronic ones, it's very easy. The guys who complain and cannot do what they want and are painful, they beg for surgery, and these are the ones that you treat surgically and that you can improve by doing a surgery. The question is, do we have to use a different treatment as for our acute cases? What is acute, what is chronic? We already, this has been defined by Claudio. Do we also need to take a graft all the time? Is this true in literature? What are the possible techniques if we do so? And what are the outcomes? What can we predict for our patients? Well, what is chronic? I think many of you will know this study, this review by Flint. If you ask the sports medicine guys, then 70% are sure what is acute. It's within the first 3 weeks. And also 70% say, well, chronic is from 6 weeks on. And the question is always, what is in between this 3 and 6 weeks? Should we still treat them as chronic cases, or what do we do in the subacute phase? Do we need a graft is the next question. There is not much studies out. We are all using grafts. I will show the consensus from the ESCA in a minute, but there is not much literature out that underlines we have to use a graft for all these patients. If we look at this study, which is one of the rare ones, it included 27 studies, minimum follow-up only 1 year. They included non-biological fixation. They included biological reconstruction CC ligament with auto or allografts, and they included ligament and or tendon transfer, the Weaver-Dunn procedure. And among level 2 studies, tendon graft augmentation showed superior results. they all showed similar complications between these groups. This is the ESCA consensus I was talking about, and if we look at the second row, then you will see that performing in tendon autograft was a very high consensus, almost 100%. So I think that also here we all agree that in the chronic cases we do use allo or autografts. There can be a discussion which one we should use, allo or autograft. This is a different point. If we talk about the surgical techniques, also like for the acute cases, there is hundreds of techniques out there, hundreds of modified techniques, and for sure there is no real golden standard that we have to follow nowadays. If you look at the surgical techniques from Weaver Dunn, like you can see on the upper side here, this could have been shown in the study from Masoka that biomechanically, at least, the free semitendinosus graft showed a significantly higher AP stability and almost close to the intact AC joint capsule. So from this time on, from this study on, almost all the AC joint surgeons switched to do these free graft reconstructions for the AC joint. What are the pitfalls with our modern techniques? We see new complications because now we do use drill holes for our techniques, and of course we do see fractures in the clavicles and in the coracoid process. Most cases of these in literature need revision surgery, so it is a really problematic complication. We did a biomechanical study on this, and of course we could show that if we use, like we did in former times, 2 4.0 drill holes in this small bone of the coracoid process, the risk is very high to have a fracture in this area. Not only fractures, what can also be a problem and what reduces the stability of the clavicle is that the tunnels, like we know from the ACL surgeries, that the tunnels do widen over time and sometimes dramatically. The size of the tunnel always sometimes even doubles over the first year. So we should be aware of this and try to use a very small drill hole in the first setting. Sorry, I have to go back. For me, it is very important in the revision surgery, but also in the chronic cases to have the right images in the beginning. When I have a revision case, the planning for me always includes a CT scan. It doesn't run. 1 second, I'll try it again. Because because you want to know what the first surgeon or what you in first time in the first case did with your drillings. If you used drill holes, then like in this case, it fractured, as you can see here, and on the X-ray on the upper right, you see that it broke out the dog bone button because it was drilled way too medial. So the bone broke out, and of course you want to know this beforehand. You do the revision surgery and think about doing more drill holes in this very small bone. So your technique depends on the outcome of your imaging. So I would encourage you to always do a CT scan before you do a revision surgery around the AC joint. This is my current technique, as you will see now, for patients who have no bigger drill holes, where I have still some place. This is a patient after hook plate, and we look under the coracoid process now. And this is a standard drilling and will be over-drilled with only one drill hole, 4 millimeters, and then you bring in the one limb of a gracilis tendon graft and the button for the dog bone under the coracoid, and then you shuttle. You are now under the in the subacromial space. You look at the acromon, and then you can shuttle down and up your gracilis tendon and knot it together above, as you can see on the pictures on the right side, on the lower. This is a technique that you, as I said, can only use if you have enough space and there is no problem with any previous drill holes. If I do have previous surgery, like you can see in this case, so there is already, the dog bone has been removed, and you see there is some bone missing, there is some defect after you remove this, so I don't want to weaken the bone anymore. What I do is I do a shuttling technique with 2 fiber tapes in this setting, and the tendon at the same time goes around the coracoid and around the clavicle, as you can see on the open pictures, and then at the same time you can use the free limbs of the graft to augment the AC joint capsule at the same time, because this AC joint capsule, of course, is always weak, and it needs to be tightened, which is very nicely done with an augmentation of this graft technique. Let me talk about the outcomes of this technique. If we look at this Masoka technique, 42 patients, follow-up 1 to 11 years. It was a free tendon CC allograft reconstruction. Like in America, often they use the allograft, and we know that it works. They show significant improvement in the shoulder function, constant score 60 to 88, which is quite good. No correlation, as we often hear, between loss of reduction and outcomes. So we can be happy that there is no correlation, because we often see this. Interesting study from data from an insurance company. 154 patients have been included retrospectively having a chronic AC joint instability. It was 4 groups: Viva done, graft CC loop, graft through the CC tunnels, or graft and the cortical button fixation technique. The revision rate was almost 10%. Again, no significant difference in terms of this between groups. However, radiological failures were significantly less in the graft and cortical fixation button group. Another study that needs to be mentioned, in revision cases, is it better to do a non-operative treatment, or can we do a non-operative treatment, and how does this technique for the revised work? They compared 14 failed non-operative treatments and 13 surgical failed treatments, and AC and CC augmentation with gracilis autograft can be recommended for both groups. There was, again, no significant difference between groups. And of course, also in the chronic cases, we have to talk about the horizontal instability. How relevant is this problem? And unfortunately, again, we have to say that the literature is very, very weak about this point. If you look at the systematic review, there is no consensus available for best practice for diagnosis, evaluation, treatment of acute and chronic horizontal instability. So up to now, we do not know if we really have to treat this in order to improve our clinical outcomes. However, neglecting of horizontal instability may lead to high complication rates and failures after surgical stabilization. But this, again, really needs to be clarified in the future. Let me summarize. From the subacute phase, 4 to 5 weeks on, we do use reconstructional techniques with an additional auto or allograft. We address the AC joint capsule if we do these surgeries, because it's not a big deal. We are doing the surgery anyways. Why should we leave it more unstable as we need to? The graft reconstruction shows similar results in delayed cases than in early reconstruction. I think this is a very important point when we discuss about our techniques in the acute ones and the indications, because now we do know that if we control them, check them after 6 weeks, and we only treat the 20% that need surgery, the outcomes will not be worse. So we don't do them any bad if we wait and see and treat them in the chronic setting. This was a very, very important study. The graft reconstruction techniques do also work for the revision cases. This is also important. And be careful, the drill holes and the fracture risks, as we say, we find high complication rates, about 10%, and it is very, very important to plan the revision surgeries properly. Thank you very much for the attention.